Cardiovascular pharmacology, lipid lowering agents. All right, so the first and highest yield one is statins that we have to know. This is the number one lipid lowering agent drug that a lot of people prescribe due to the fact that it has such great effects at lowering your LDL. So first and foremost, it lowers the LDL drastically, and it has some increase on HDL. Now, what are they going to ask you about? They're going to ask you about the mechanism of action for statins, okay? By the way, all statin drugs, they end in statin. Very helpful. The one that you count on your nose, atorvastatin, but they all end in statin. You know it's a statin drug. The mechanism of action is going to inhibit HMG-CoA reductase. If it says the mechanism of action is something else, then it's not a statin. Statin's mechanism of action is inhibiting HMG-CoA reductase. And HMG-CoA reductase, all that it is that it is the rate-limiting step for cholesterol production, okay? So that's all that it is. So if we inhibit the rate-limiting step for cholesterol production, then we have an overall decrease in cholesterol in our body. So then that leads to decrease in intrahepatic cholesterol and an increase in LDL receptor recycling, as well as an increase in LDL catabolism, okay? So breakdown of LDL, so that we could get more cholesterol, right? So this is one and the only drug of the lipid-lowering agents that decreases mortality in patients with CAD. So here's another decrease in mortality drug. You have to know them. It's the statins. Now, the adverse effects that we're going to be looking out for is myopathy is number one. Myopathy is just muscle aches, okay? So patients are going to come in with muscle aching. Another drug, lipid-lowering agent that causes muscle aching is myopathy is fibrates. So you can't use fibrates with statins. They're contraindicated. But, I mean, you can, but you just got to worry about this myopathy as an adverse effect. And then lastly, you have to check the LFTs, which are just liver function tests, just to make sure that there's no hepatotoxicity, because statins can lead to hepatotoxicity. Next is bile acid resins. Bile acid resins, the drugs begin with CHOL, C-H-O-L or C-O-L, okay? And that's how you're going to tell that it's a bile acid resin. And what the mechanism of action behind this is that it's going to block the reabsorption of bile, okay? So what happens is when we excrete our bile into our GI tract, majority of it actually gets reabsorbed at the terminal ileum, okay? Now, if we give a patient bile acid resins, it's going to bind to the bile acids, and it's going to just, essentially you're going to poop it out, right? It's going to go to the waste product, and we don't reabsorb that bile anymore. Well, without reabsorbing bile, then the body's going to have to use up its cholesterol in order to form more bile, because that's how bile is made, is through cholesterol. And so that's how it decreases our overall cholesterol. So it increases conversion of cholesterol to bile. That's the mechanism. And overall, it's going to decrease LDL, not as much as statins. Nothing's going to be as much as statins. So it's just going to decrease LDL, but not as much as statins. The only adverse effect that we really should care about is that you have a decreased absorption of other drugs and fat-soluble vitamins, because you're not reabsorbing the bile acid resins, okay? Next is ezetimibe. Ezetimibe's mechanism of action is that it's just going to prevent cholesterol from being reabsorbed, okay? Or not even reabsorbed, just from cholesterol being absorbed originally from our diet. So if I eat anything that contains cholesterol and I'm taking ezetimibe, it's not going to be absorbed at the brush border enzymes, okay? At the brush border cells. And so that overall decreases my LDL because I don't have enough cholesterol, okay? Next is fibrates. Fibrates are probably the second highest yielding that they're going to ask about. And what you should know is that they are specific for severely decreasing triglycerides. Okay, so we're going to use fibrates to decrease triglycerides. And the two drugs are fenofibrate, so fibrates in the word, or gemfibrozil. Okay, so fibro is in the word as well. Now, the mechanism of action is very specific as well. It activates PPAR alpha. So PPAR alpha, which leads to an upregulation of LPL, and that leads to an increase in triglyceride clearance, okay? And overall, you're going to see a drop in VLDL, okay? So a question that they might like to ask is why do fibrates take a while to kind of work? It's because they activate PPAR alpha as their mechanism of action. And as we know, for activating PPAR alpha, and you might not know this, but you have to get to the nucleus in order to activate PPAR alpha. So it takes a while to work because you actually are affecting transcription and translation, okay? And then lastly, the adverse effects of fibrates is myopathy, right? We already said that increased risk with statin usage as well is going to cause an increased risk of myopathy with fibrates. Also, another thing is gallstones. So cholesterol gallstones are going to be increased risk factor with patients that are taking fibrates because they inhibit cholesterol 7-alpha hydroxylase, okay? So that might be a question they'll ask you closer probably towards GI section, but it's important to remember right now. I mean, I'm going to talk about it later on for the GI section, but fibrates have an increased risk of cholesterol gallstones due to the fact that it inhibits 7-alpha hydroxylase, okay? Next is niacin. Niacin, once again, is one of the three high-yield things that we have to know for our lipid-lowering agents. We already talked about statins, which is the main thing that lowers LDL. We talked already about fibrates, which is the main drug that lowers triglycerides. And then finally, we have niacin, which is the main drug that increases HDL, okay? So it's the most effective at increasing HDL. And now the mechanism of action, all that it does is that it inhibits lipolysis, okay? Hormone-sensitive lipase. And it reduces hepatic VLDL synthesis. Now, they don't really like to ask about mechanism of action for niacin as much. I mean, know it, but it's not really that important. What you need to know is that niacin, all that it is vitamin B3. Okay, niacin is just vitamin B3. Okay, and it increases that HDL, most effective at increasing HDL. And then the adverse effect is probably one thing that they always ask about. You're going to get a flushed face when taking niacin. Potential adverse effect is flushed face when taking niacin. Okay, and the reason behind it is because you have prostaglandins that are just going kind of haywire. Okay, and so if we have an increase in prostaglandins causing this flushed face secondary to niacin usage, they will always ask you, what do you give the patient? Well, to decrease this adverse effect of flushed face, we're going to have to give something that drops down prostaglandins, that decreases prostaglandins. And what do we know that does that? Is NSAIDs. Okay, so we have to give the patient NSAIDs in order to decrease the prostaglandins, which is causing the adverse effect of flushed face secondary to niacin usage. All right. Two other things that niacin causes is hyperglycemia and hyperuricemia. And hyperuricemia just leads to gout. Okay, uric acid increase. Okay, so hyperglycemia and hyperuricemia are two other things that you have to know about niacin for adverse effects. All right. Next is PCSK9 inhibitors. These end in CUMAB. So CUMAB. If it ends in that, then you're looking at PCSK9 inhibitors. These are very good at decreasing LDL, but they're only usually used in very increased risk patients with recent MI, okay? It's not really asked about. They don't really talk much about it or test much on this, but the mechanism is important to know. You have to know the mechanism because they will ask about the mechanism. So PCSK9 inhibitors, what they do is that they inactivate LDL receptor degradation. All right, so that leads to increased removal of LDL from the bloodstream. So what normally PCSK9 does is that it will degrade the LDL receptors, okay? But if we give an inhibitor to PCSK9, then we're going to block the degradation of LDL receptors, leading to an overall increase in LDL receptors, which brings in more LDL to the liver, right, and breaks it down. Okay, so that's all we want. That's all you really need to know is the mechanism of action for PCSK9 inhibitors, ending in CUMAB. Lastly is fish oils and omega-3 fatty acids. You don't really know about this. They don't really test on it. So don't really worry about it. That's all for lipid-lowering agents. What I will say is just remember those main three ones. Statins overall decrease LDL and their mortality. They decrease mortality. Fibrates used for decreasing triglycerides, and niacin used for increasing HDL. All the other ones, you have to know kind of the mechanisms of action. They love to ask about those and know the adverse effects that I covered.